Good morning, good afternoon, and good evening, esteemed professors, doctors, guests, colleagues, and participants from all over the world. Welcome to the Art of Managing Osteogenesis Imperfecta in a Resource-Constrained Setting, an international webinar conducted by Global Pediatric Endocrinology and Diabetes. This international webinar is conducted alongside Wishbone Day. Through this webinar, GPED hopes to help health professionals recognize and diagnose OI, to understand the importance of intravenous bisphosphonates in the treatment of OI in children and adolescents, and to discuss the challenges in providing sustainable access to bisphosphonates to patients. Before beginning today's webinar, we would like to inform you of the rundown of this webinar. We will begin with a welcoming address from the President of Global Pediatric Endocrinology and Diabetes, followed by an introductory address by Dr. Phoebe Wamalwa. This will be then followed by our keynote presentation entitled The Management of Osteogenesis Imperfecta, State of the Art by Dr. Mary F. Robinson. The second presentation will be brought to you by Dr. Speciosa Mbulanguku, entitled The Machakos Orthopedic Clinic, Bringing Smile to Children with Osteogenesis Imperfecta. Today's webinar will be then concluded with the discussion session. For the smooth running of today's event, kindly pay attention to the following rules and regulations. Participants are encouraged to have their videos turned on throughout the webinar. Participants should keep their microphones off unless permitted by the moderator. And to obtain a certificate of attendance, participants are required to attend the entire duration of the webinar and fill in a feedback form. To officially open the webinar, we will now respectfully invite our first speaker to deliver the opening remarks. Without further ado, to the professor who needs no introduction, to Professor Jean-Pierre Chanoine, the time and screen is yours.
Good morning, everybody. Thank you so much, Arnetta, for your kind introduction. As you may know, GPED is a non-profit organization which was established in Canada in 2010. The GPED aims at providing the care of, at improving the care of children with endocrine disorders or with diabetes living in low and middle income countries. And we are one of the 14 regional societies in pediatric endocrinology around the world. Some of our activities are educational, like today, and you will soon be invited to attend our first international meeting in the fall. We offer webinars for World Days, but for this particular webinar, the achievement of Dr. Mbula at the Machakos Orthopedic Clinic in the management of osteogenesis imperfecta and the need for sustainable access to biphosphonates prompted GPED to organize today's seminar in honor of the Wishbone Day that takes place on May 6, 2024. And I want to thank Dr. Mark Ansermino, pediatric anesthesiologist in Vancouver, who put GPED in contact with Dr. Mbula. As we all know, achieving sustainable access to a medicine is very difficult in many countries, and it involves the collaboration between many actors, including health authorities, parents, health professionals, pharmacies, and the pharmaceutical industries. And we hope that today's webinar will represent a small step in that direction. We will hear a state-of-the-art lecture by Dr. Mary F. Robinson, and a description by Dr. Mbula of her work at the Machakos Orthopedic Clinic, where she follows 47 patients and adolescents with osteogenesis imperfecta. I want also to especially thank Arnetta, Elena, who is GPED manager, and Anissa, who are doing a fabulous job at organizing our webinars. And today we have more than 300 attendees from 30 countries who registered. At the end of this webinar, you will be asked to answer a questionnaire that will help us understand the needs with regards to the management of OI in your particular setting. And you will also, as Arnetta mentioned, receive a certificate of attendance. I now have the pleasure of welcoming Dr. Phoebe Wamalwa, who has kindly accepted to give an introduction. This is really important that Dr. Wamalwa has been able to join us. She's the president of the Pediatric Endocrine Society in Kenya, and she's a pediatrician and a pediatric endocrinologist at the Kajiado County Referral Hospital in Kenya. Traditionally, very often, pediatric endocrinologists around the world are involved in the management of patients with osteogenesis imperfecta, and therefore it's really very, very nice to have pediatric endocrinologists joining Dr. Mbula and trying to work together towards better care in osteogenesis imperfecta in Kenya. I hope that this webinar will serve a little bit as an example, but also will help us realize that by ourselves, we just cannot do anything. We really need to work collaboratively. And in particular, we need to involve our families and our patients in the management of their conditions. So without further ado, I will invite Dr. Wamalwa to give her introductory comments. Thank you, Phoebe.
Thank you very much, Prof, for that kind introduction. Good morning, good evening, colleagues. I hope my screen can be seen. So yes. I was asked to do a 5-minute presentation on the Kenyan experience from the pediatric endocrinologist perspective. So in terms of epidemiology, we actually don't have incidence or prevalence data in Kenya. However, there was a while ago, we had a 14-year retrospective study that was done at AIC Kijabe Cure Hospital between 2000 and 2014. And the osteogenesis imperfecta was found to constitute around 2% of all the cases that had been seen in that hospital. So that basically giving us a number of 80 cases. And majority of these patients were noted to come from one particular region of Kenya, and that was the eastern region, with around 27% coming from Machakos, where Dr. Specky is, and 30 out of the total 80 patients were basically from the Kamba tribe, basically predominates the Machakos region. So clinical presentation determines age at diagnosis. Why? Because osteogenesis imperfecta has different types, and the presentation may vary, though majority of cases are classical. And we know that it may present with skeletal features, including multiple atypical fracture, short stature, kyphoscoliosis, and sometimes basilar skull deformities. And extraskeletal features include all those, including the blue sclera, the abnormal teeth, respiratory insufficiency, including hearing loss, which is more in adults, joint hyperextensibility, and also cardiovascular and CNS features, hence delayed or missed diagnosis. And we have seen cases where these children have actually gone from doctor to doctor, and diagnosis of renal tubular acidosis has been made, or even child abuse and other brittle bone disorder. So we need multidisciplinary care in terms of pediatric endocrinologists, orthopedic surgeons, plaster technicians. They need psychosocial care, pain management specialists, physiotherapists. And the question we have is, who should be the team lead in all this? So what's the general landscape in Kenya in terms of management? Majority of our patients with osteogenesis imperfecta are under the care of orthopedic surgeons because they present with fractures initially. And the use of biphosphonates after surgical intervention is variable. We have our colleagues in the surgical field who start the children on bisphosphonates, others do not start. The biphosphonate choice is dictated by the cost. And so we see a number of our patients being put on oral alendronate, for instance, because of the cost. But the patients who are undergoing follow-up in our main referral hospital, that is Kenyatta National Hospital, are under the intravenous biphosphonate, and whatever we use there is mainly zolendronic acid. So initially we start with 3 monthly zolendronate, followed by, for several doses, followed by 6 monthly IV infusion of zolendronate. So how has the outcome been in the national referral facility? So patients in this hospital have been noted to have marked reduction in fractures after 4 to 6 doses of zolendronate. And the delayed milestones are there, but they tend to catch up with proper physiotherapy and occupational support. The available biphosphonates in Kenya are mostly we have intravenous zolendronic acid, but they come in 4 milligrams per vial, yet our children require very minor doses. So you find that we have to really use a small dose out of this vial. IV pamidronate is not easily available, but also the cost is prohibitive. Oral alendronate is there, and it's a cheaper option. The question is, how is the efficacy compared to the intravenous biphosphonate? So the access to treatment affects retention. Why is this? It's because a number of patients stay away from the hospitals that offer these services, and so we have missed appointments because a number of them, or majority of our patients, will require a day's admission to be given proper infusion. Then affordability is also a concern. Then we have pre-infusion tests, including bone chemistry tests and renal tests before the pharmacist releases these biphosphonates to the patient. And then, of course, we have to also do radiological tests to check the healing of the fractures. And these patients, more often than not, also require supportive care costs. So what will be the future considerations? As it is right now in Kenya, we need nationwide baseline study on osteogenesis imperfecta. We need to create awareness of this condition amongst healthcare workers. We need support groups. We need advocacy. And then how do we assist these patients in covering management costs in terms of access to the health facility, the tests, the biphosphonate treatment? And then in future, perhaps we may consider genetic diagnosis to answer some of our questions as to why majority of these patients that were seen in Kijabi Hospital, one of our mission hospitals, came from one region, that's the Eastern region. Thank you very much. Over to you, Prof.
Thank you, Margaret Phoebe, for this scenery of what's happening in Kenya. I think this is a very nice introduction, and that will be a nice introduction also for the presentations by Dr. Robinson and Dr. Mbula. I would like now to invite Dr. Agostini, who has kindly accepted to chair the question and answer session and to chair the rest of the webinar. Dr. Agostini Utari is a pediatric endocrinologist from Diponegoro University in Semarang, Indonesia. She holds a master's degree in genetic counseling. She did a year of research fellowship on Fragile X syndrome at the Mind Institute at UC Davis in USA, and she obtained her PhD from Nijmegen University in the Netherlands. She currently serves on the National Newborn Screening Committees in Indonesia, among many other jobs as a volunteer job, and she's vice president of GPED. She will be organizing her next webinar on thyroid disease in honor of the World Thyroid Day, which is coming on May 31st of this year. So, Agostini, thank you very much, and the floor is yours.
Okay, thank you, JP, for your kind introduction. So today, I'm very grateful for having all of you here, and we will start with our keynote lecture. First, we will have Dr. Mary-Eve Robinson, and she's from Children's Hospital of Eastern Ontario. Dr. Mary-Eve Robinson is a pediatric endocrinologist, specialist in genetic bone diseases at the Children's Hospital of Eastern Ontario, and she is graduate of McGill University Medical School. She completed a pediatric endocrinology fellowship at the Montreal Children's Hospital and also in the Schreiner Hospital for Children in Canada. Then she completed a skeletal dysplasia course in Lausanne, Switzerland. Dr. Robinson has treated hundreds of patients with osteogenesis imperfecta and has done research to better characterize their phenotype, including pain, as well as understand of the role of biphosphonate. Dr. Robinson is the clinical director of the Strong Clinic, a multidisciplinary genetic bone disorder clinic which aims to provide comprehensive care of children with genetic bone disorder like osteogenesis imperfecta. And Dr. Robinson strives to improve, build, and disseminate good practice in musculoskeletal research for young investigators around the globe through her role as the chair of the International Society on Children's Bone Health, New Investigator Networking Group. Finally, she is involved in the outreach program aimed at improving the care of children with bone disorder living in developing countries such as Haiti and Ecuador. Welcome, Dr. Robinson, and time is yours.
Wonderful. Thank you so much, Tari. Thanks for that kind introduction. It's a real pleasure for me to be here with you today. I'm really pleased to see so many people that are involved in OI and want to hear more about OI. So thanks so much for allowing me to be here. So I'm going to talk about state-of-the-art management in osteogenesis imperfecta. Those are my disclosures. I do a few trials for rare bone disease, different drug trials. So here are my objectives. So I want to first talk about how to recognize and how to diagnose osteogenesis imperfecta. Then I want to talk about specifically the importance of intravenous bisphosphonates. Why should we use them? What the evidence is showing us. I'm focusing today on pediatrics, so children and adolescents. And then I want to discuss really practically what you need to know to safely prescribe bisphosphonates. So the first objective, so we're going to talk about how to diagnose OI. So as was briefly discussed earlier, OI has a wide range of severity, all the way from really mild form, almost hard to diagnose, to lethality at birth. So typically we try to characterize OI based on severity. We're trying to move away from the various types of OI because we were kind of at a very high number of OI types. So we're going back to basic and going by severity. So when we talk about OI, mild type of OI, we're typically talking about children that have either normal or slightly low stature, have an easy fracture, so low trauma fractures. They can have a mild scoliosis. And typically those children can walk around. They don't need assistance to walk. The severe type of OI, which classically is called OI type 3, those are children born typically at birth with a high number of fractures. They can have very severe scoliosis, severe limb deformity. So usually those children will need rodding surgery of their limbs, spine surgery, and they have very high number of fractures. And most of those children are not able to ambulate alone. So they'll be wheelchair bound. In between mild and moderate, you have the moderate, and between mild and severe, you have moderate OI, which is really kind of a moderate phenotype. So moderate short stature, moderate limb deformity. Usually those individuals will be able to ambulate with some sort of walking assistance. And the one clinical factor that you can use to differentiate the severity is actually height. So height is strongly associated with severity. So if you have severe short stature in OI, you'll typically have a very severe phenotype. OI can be both dominant and recessive, and I won't talk a lot about the genetics aspect today, but just to mention that most cases of OI are dominant. So you'll have either a family history of OI or you have a new mutation, and typically that's in the collagen type 1 gene. So that would be COL1A1 or COL1A2. So those are the most common cause of OI. And you have recessive forms of OI, which it's interesting that you just earlier that was said about there might be kind of a little pocket of children that have more OI in Kenya, and maybe that actually is from a recessive type of OI, which is typically when we see lots of children having OI in the same kind of area. I'm just showing that here to kind of, I mentioned earlier that we're moving away from talking about OI of various types, and we're going back to talking about OI by defining OI by clinical severity and by the name of the gene, if that's available. So there's a paper just recently published about how to classify a genetic bone disorder in 2023. And really what that's suggesting now is to talk about OI, basically just describing OI, non-deforming type, and then you would say what the name of the gene is. So we're moving away from talking about, like, for example, an OI type 10 and really describing the clinical severity with the name of the gene. So I'll kind of stick with that throughout the talk today. So I'm going to show a case. So this is a baby that actually we were consulted on prenatally, and there was a number of fractures that were found in utero, very short, long bones. And the team at the time actually had told the family that this baby would pass away at birth, and the mom had donated all their clothing and all their baby equipment to the hospice. When the baby was born, that's her chest x-ray here, so you can see that the ribs are a little bit thin. She actually was intubated right at birth because of severe respiratory distress. She had a very thin skull and very severe plagiocephaly. And this is her x-ray of her spine. So whenever a child is suspected to have multiple fractures, a good first step is to do a full skeletal survey to look at all the bones, and that includes the vertebral body. And she actually did not have vertebral fracture, which sometimes is seen in very severe OI at birth. This was a leg x-ray, so you can see her bones are shorter, very heterogeneous, very coarse, fractures already, so fracture that would have happened in utero. So with this information alone, you can actually make a diagnosis of OI. You don't actually need genetic testing. You don't even need a bone mineral density examination. You can tell that this patient has OI based on the fact that there's multiple fractures, based on the appearance of the bone. This baby was actually started on bisphosphonates. And I'm showing that because that's part of what I'm going to try to convey through the talk, is the importance of starting bisphosphonates as early as possible, so as early as 5 days of age in babies, because you can really help them in terms of long-term outcome. So this baby was started on zoledronate, which typically is given every 3 months for the first 2 years of life, and then every 6 months afterwards. That's her leg here at 4 months. You can see the bones actually look quite different. There's fortunately no fractures, but there is still significant bowing. And the bisphosphonates actually don't help really with bowing. The only way to help with the actual deformity of the bone is surgery. The bisphosphonate will make the bone stronger and fracture less, but as long as the bone is bowed, you can have a risk of breaking it. This is a density test of that baby. So what you could see here is on this y-axis, you have the bone mineral density. This is using DEXA scan. I'll talk a little bit later about DEXA. And that's the age here. And the patient data is in red. You can see at baseline, so right at birth, the patient actually had normal bone mineral density. That's very common in OI, especially in infants. And so this is why this is not a test that we're using to diagnose OI. We're really diagnosing based on the clinical features in the X-ray. This patient, because he was started on bisphosphonate, you can see that he continued to have a normal density. But if you had had the same child without treatment, you would see a plateauing of the density, and the child's not able to accrue new or healthy bone. This is an X-ray of that patient arm at 1 year. And what I'm showing here is you can still fracture, in a patient with severe OI will still fracture despite bisphosphonates, because bisphosphonates are very good, but they don't fully reduce all fractures. So patient with severe OI will still fracture. So I talked a lot about the X-ray finding, about the clinical diagnosis of OI mainly being around fracture, so low trauma fracture, X-ray finding, but you can have other that we call extraskeletal manifestations. There's a number of them. And when we talk about those are typically seen when we refer to classic OI, or the types of OI that are caused by type 1 collagen mutation. And that's because collagen is everywhere. It's in your sclerae, it's in your ligaments, it's in your dentin, it's in your heart, it's for hearing. So that's why we have so many of those extra bone problem in OI caused by collagen mutation. So when you see those patients, those could give you a clue into the diagnosis, but if they're absent, you could still have OI. So they're not always there. Plus, they're not going to be there if you have a type of OI that's recessive, for example, or that's not caused from collagen mutation. So typically those extraskeletal manifestations are blue sclerae, so kind of like the gray or the blue, the sclerae are blue or gray or blue. Scoliosis, because of the ligament problem, which is what gives rise to scoliosis, ligamentous hyperlaxity, and the dentinogenesis imperfecta. The dentinogenesis imperfecta typically specifically involve the primary teeth. So baby teeth will be more affected than adult teeth. And it's a dentin problem because of the collagen issue. And what you'll see is very kind of a gray or pale teeth that are brittle. So you can have fractured teeth. And children with OI also often have malocclusion. So they'll sometimes have a hard time putting their teeth together, and that will impair eating. That's separate from dentinogenesis imperfecta. That's actually a problem of occlusion. So you can have either or. So when you have a child that's coming in with recurrent fractures, or even the child I showed you initially with prenatal and even natally found fractures, what is the standard workup for a child with possible OI? So you want to suspect OI whenever you have a history of low trauma long bone fracture. What does that mean? So that means that you're fracturing a long bone, so humerus, a radius, a femur. You're fracturing a long bone in a setting where you shouldn't have. So any bone will fracture if you give enough trauma to that bone. But when we call low trauma, that means that someone is fracturing at no more than a walking speed and no more than a standing height. So if a child is actually walking and falling from his own height, that is not normal. That's a low trauma fracture. So whenever you hear low trauma fracture, that's when you want to start worrying about a bone fragility condition. The hands and toes, we don't really care about as much. We're really talking long bones. And of course, if you have those extraskeletal signs, you also want to think about OI, right? That's pointing toward that collagen type 1 mutation I was telling you about, but you don't need that to make a diagnosis of OI. All you need is a history of the low trauma long bone fracture. And then you want to kind of try to differentiate if you think that's genetic or OI, or if you think it could be secondary osteoporosis, for example, if the patient's on steroids or there's another systemic condition causing the bone fragility. So in terms of the test to be done when you have a child presenting to you with this history and potentially with extraskeletal signs of OI, if you had just one test that you need to do, that's a lateral spine X-ray. And that's to look for vertebral compression fractures. So you want to see if there's fractures of the vertebral body. This is a very easy test to do. And if you don't do it, you might miss those fractures. And if you don't treat those fractures, you might end up with multiple vertebral fractures. We can have really bad outcome in terms of respiratory compromise, kyphosis, severe pain. So it's really important to not miss those. So you want to do that at diagnosis and then annually in those children. If you have access to dual X-ray absorptiometry, that's great. There are reference data from birth all the way to adulthood and obviously in adults. Sometimes though, the actual manufacturer do not make that available with the actual DEXA scan, so you might not have that part of your DEXA machine, but they're easily accessible online. You can find those reference data. You can even have charts of bone mineral density by age, and you can plot your patient on those charts even as early as a few months of age, and you can then track their scores. Important blood work to do in OI is to look for calcium deficiency or vitamin D deficiency, because you don't want that to exacerbate your bone fragility. So typically I would do a baseline calcium, phosphorus level, magnesium, 25 hydroxy vitamin D, and renal function. The reason we want to look at renal function is if we need to start bisphosphonates, we need to confirm that there is no renal failure. If you have genetic testing available, great. But as I said, that's not needed to make a diagnosis of OI. So in summary, for the diagnosis of OI piece, OI is a clinical diagnosis based on the presence of low trauma long bone fractures. And sometimes you can have those extraskeletal signs of OI. And when you have excluded a secondary cause of this bone fragility, so there's no other medical condition or osteotoxic medication that the patient's on, you can make that diagnosis without genetic diagnosis. And OI is not classified based on phenotype, mild, moderate, or severe. And if you have the gene involved, you would name that gene whenever you're talking about the OI, but the phenotype is really the key. So now I'm moving towards the understanding the importance of intravenous bisphosphonates in the treatment of OI. So what are bisphosphonates? So bisphosphonates are analogous, so they're analog of pyrophosphate. So I'll have a little graph here just to show how they work. So this is an example of a bone that's not treated. So here in this cartoon, you have those nice square cells. Those are the osteoblasts. They're in charge of forming new bone. They're laying down what's called osteoid. Osteoid is shown here in red. That's the unmineralized bones. They're laying down bone that doesn't have calcium yet. The osteoid will then be calcified. So that's shown here in green. So calcium will be laid on the osteoid, will become stronger. That's the hydroxyapatite, that is the bone. And then you have those large multinucleated cells, which are osteoclasts, that are resorbing the bone. So in a child, you have somewhat of a balance between the bone added by the osteoblast and the bone resorbed by the osteoclast. When you give bisphosphonates to a child that's growing, what we do is we intoxicate the osteoclast. So the osteoclasts are trying eating the bisphosphonate, they get intoxicated, they no longer work. And so now you have this new bone that was not removed this time. So you're ending up with a thicker bone because the osteoblasts are no longer eating up your bones, but the osteoblasts are still laying out the new bone. So the net effect is you'll have here a thicker, that's a cortical bone here I'm showing you, you'll have a thicker cortex in that example. And the bisphosphonates attach and remain the skeleton for years, 20, 30 years, which is why we love them so much in pediatrics, because whenever we have a genetic defect, we want to give a medication that is long-lasting and will stay in the bone as much as possible. So that was mentioned a little bit prior about oral versus intravenous. We do not use oral bisphosphonates in OI. They're simply not as efficacious. What the studies have shown in that with an oral bisphosphonate, you're not protecting the spine in OI. You can still have new vertebral fractures. And that's really why we don't use them, is because it's really important in children in OI to prevent fractures in the spine, and that the oral bisphosphonates are not potent enough to do that. So we always use intravenous only in the growing years. There's different type of molecule of intravenous bisphosphonates. In the same way, for example, with penicillin, you have amoxicillin, penicillin, they're kind of sister medication. Same concept for pimidronate and zoledronate. They're both the same molecules. I'll show how they differ, but they're both very good in treating OI. Here, I want to talk about what are bisphosphonates actually doing. Now I have one slide per kind of effect. So the one thing that bisphosphonates do really well is increasing bone mineral density. So here's an example of a DEXA scan where a person's lying down and the machine is acquiring the bone mineral density by the DEXA scan. In OI, when we look at that, we see that bisphosphonates actually really are very helpful at increasing the bone mineral density for children. So that's a really potent effect. And when we do the same medication in adults, they don't quite work as well because adults don't form a lot of new bone like the children bone do. And that's why bisphosphonates are very good in pediatric, because you're able to block the osteoclast and the osteoblasts are still forming a lot of new bone during growth. Bisphosphonates also decrease fracture rate. So this is just a visual example to show you when we give bisphosphonates to those patients here, the arrow are showing the number of fractures. And with bisphosphonate, which is the yellow line, you have a reduction in number of long bone fracture. Now you're seeing those are not reduced completely. It's about 50% decrease. So you will still see ongoing fractures in OI. And that's part of, it's just, we're not rescuing the phenotype completely. And we have new drugs in development to hopefully do that even better. But for now, bisphosphonates don't completely rescue the long bone fractures, but they do a pretty good job. Bisphosphonates are especially good at the spine, and that's because the spine is full of trabecular bone, and bisphosphonates are very good in trabecular bone. So this is an example of a child with a moderate form of OI. That's a spine X-ray, and I'll show you a little bit more how to read this, but you can see that the vertebral body and the spine are collapsed. So that gravity was kind of won the war, if you will, against the vertebrae, in the sense that it led to the vertebrae being squished. And when you treat that child with bisphosphonate, you can have what's called reshaping of those vertebral body. And that's a phenomenon in OI that you can only have when you're still growing and when you add the bisphosphonates. There are some report of children being able to heal their vertebral fracture without bisphosphonates, but this is extremely rare. Usually they'll need the help of bisphosphonates to do this. This is another example of a very young child with also fractures in their vertebral body, and with treatment, you're able to reshape. So that's really why we want to start early and we want to continue treating, because we want to protect that spine during childhood. This is how we read vertebral X-rays. And I just want to pause and talk a little bit about this, because a lot of radiologists are not necessarily trained into reading vertebral fractures. And very often, if you just do an X-ray and you read the report, it will be read as normal. And it's important, I think, as endocrinologists and other specialists involved in OI, to actually look at the X-rays ourselves and see if there are a vertebral fracture, because that's our cue to start therapy. So a vertebral body that's normal, it should be like a nice square on a film. And when you have a fracture, you have a loss of height of the actual vertebral body. So it could be all the way from 20%, which we call that mild, to severe, which is over 40% loss of height. But the loss of height is really kind of your cue to the fact that something's going on and there might be a vertebral fracture. And you could lose that height in different ways. You could have wedge deformity when the interior portion is more compressed into posterior portion. You can have a biconcave when the middle is compressed, or a cross deformity where all the vertebrae is compressed. And so that's important to watch and to monitor during bisphosphonate. Bisphosphonates don't help scoliosis. That's the story. So you'll need surgery for that. They're very potent at treating pain in OI, and that's a really common problem. Children in OI have bone pain, and bisphosphonates are potent at reducing that bone pain. And sometimes when you try to stop them, children will tell you, well, I'm having pain recurrence, and we might sometimes treat the bisphosphonate just for the pain effect because it's such a potent effect. And to give you a sense, typically the pain effect of bisphosphonate occurs 2 weeks after we give it. So that's when the patient are going to tell us, yeah, we feel better at 2 weeks, and can last months. And that varies from patient to patient how many months the pain effect lasts for bisphosphonates. It also improves the muscle strength, so makes them stronger. They have better stamina as well. And then that's the latest data that we just haven't published yet, but we're actually seeing that bisphosphonates also lead to better height. So when you treat patients with bisphosphonate, they have a higher height Z-score at the end of growth. Just to give you a sense in centimeter, in OI, the severe type of OI, they gain about 11 centimeters just from the treatment with bisphosphonate. And the earlier, when you start bisphosphonates early here, the more of a difference you'll have in your height Z-score. So the earlier you start, the better effect on your height. So those are the effects, and I'll summarize that at the end of my slides. Here, when I compare cylindronate versus pimidronate, that's a question that comes up often. Again, I mentioned their sister medication. The main difference is that pimidronate is a little bit less potent than Zol. It needs to be given more often. So usually cylindronate after the age of 2 years is given every 6 months, and pimidronate is given every 4 months. The duration of the infusion cycle is very different. So for Zol, typically takes about 45 to 50 minutes. We usually don't admit those children even with their first infusion. We give the infusion 45 minutes, they're out the door. With pimidronate, depending on which protocol you use, you could do a 1-day protocol, and that takes 3 hours, or sometimes you might need to do a 3-day protocol depending on your dose. And so if you talk about the number of hospital visits, it's way less for cylindronate, and that's why it's typically preferred, and also, as I mentioned, it's a little bit more potent. When you compare Zol versus PAM, what you see is that the bone mineral density is a little bit better on Zol because it's a bit more potent. But when you look at fracture rates, so the number of subjects with fractures on Zol versus PAM, it's the same thing. So really clinically doesn't really make a big difference. They're both kind of working okay, whatever works best in your setting, and from a cost perspective as well. PAM is less costly, but also given more often. That's a summary of what bisphosphonates do in OI. They increase bone density, they reduce the number of long bone fracture, they foster a vertebral body reshaping, so they heal previously compressed vertebral body, and they also prevent new vertebral fracture, which is very important. They reduce pain, and they increase your muscle function. Who do we treat? Because we don't want to treat all patients of OI. Remember how I mentioned that the mild form can be very, very mild. So we don't, and bisphosphonates are not, they're very safe, but they're not, they have some side effects, which I'll discuss briefly. So you want to treat a child at the earliest sign of bone fragility, if that bone fragility clinic is significant. So what does that mean? If there's vertebral fracture, you want to start treatment. No matter how many, you just need one. Even if it's a mild vertebral fracture, you want to start treatment. Typically, we also start treatment if you have one significant low trauma long bone fracture. What does that mean? So if you have a child that has a humerus or a femur fracture without significant trauma, so fell from a sitting height or fell from a walking speed, this is a reason to start bisphosphonates. If you have 2 or more long bone fractures that are not major, so typically we talk about like if you have a radius or a tibia, you might want to wait for a little bit more fractures. So 2 long bone fracture in the last per year in the last 2 years, then you might start treatment. And the reason for that is we don't want to over-treat. So if you don't have a major event, we watch and then we start when you have more significant number of fractures. You also want to treat if you have pain that's interfering with quality of life, even if you don't have the fracture history, because pain is very important to manage. And those children can go from not walking to walk and to be walking just from a pain perspective. Here, I'm going to share a case just to make the point of why it's so important to start bisphosphonates early when you have early sign of bone fragility. This is a little, a few month old baby that was playing with dad to pull to stand and sustain a femur fracture. Her bone mineral density, that score was quite low. So in this patient with just this history, you need to start bisphosphonates because she has that one low trauma fracture. She clearly has bone fragility. There's no other systemic problem. She's not on medication, so she needs to start treatment. Now, this patient was seen at another institution and did not start treatment. And you could see at the time where she fractured her femur, that was her spine x-ray. So she had a beautiful spine x-ray. The vertebral body were normal. And at 15 months, see how her spine is fully collapsed. And now you have those vertebral plana, so very severe vertebral fractures. And that could have been avoided if treatment would have started right at this 5-month mark. And now she has a fully collapsed spine. So very important to start early. How do we treat? So we treat bisphosphonates, I mentioned, intravenous. Before you start treatment, you always want to document normal calcium, normal vitamin D. And if it's not normal, you need to supplement that before you treat. So if you have a low vitamin D, less than 30 nanomole per liter, you want to supplement this, wait until it's over 30, and then do your infusion. This is the algorithm for zoledronate that was published. You can go back and find a protocol if you wish. The bottom line that this slide is saying is that you want to adjust your dose of zoledronate based on your bone mineral density result. That is typically done every 6 months because you want to avoid over-treatment because you can over-treat an OI, it can be very detrimental. And you want to keep going with your treatment until you're done growing. When you're no longer growing, that's when you can stop your bisphosphonates. The first ever dose that's given needs to be a quarter of a typical dose. That's to lessen the side effects. So that's 0.015 milligram per kilogram for the first ever dose. And that's really important to reduce the side effects. How long do we treat for? If you have a genetic cause or if you're suspecting OI, you want to treat until the patient is done growing. So that means that there's no more height achieved and that the bone age is showing that growth plates are fused. Why do we never stop bisphosphonates during growth? That's because in OI, children are growing, and when you treat, you'll have stronger bones. And if you stop treatment, there's going to be new bone that's formed, and this new bone is very weak. So you'll have an interface of old treated strong bone and weak treated new bone, and you can fracture right at this interface. So as long as your patient's growing, you want to keep your doses of bisphosphonates, and you can never give them a drug holiday because you might have those fracture at this interface of the old treated bone and the new untreated bone. What happens when we stop treatment at the end of growth? Most actually adults do okay. So the bone mineral density is actually maintained after stopping bisphosphonates. And adults don't have more vertebral fracture or more long bone fracture in the 4 years after stopping bisphosphonates. We don't have long-term data. We don't know how they do more than 4 years after stopping the bisphosphonates, but we know that really in that 4 years, they're okay. Here, I just want to show that in adults, when you talk about OI versus healthy population, so OI here is in red, that's for female, they will have a very high risk of fracture during childhood. And in adulthood, the risk of fracture is much lower, but still higher than the general population. But really the risky period is around puberty and around childhood, and then the fracture goes down, but it's still higher. Same thing for males, although they don't have the menopause aspect, so they're a little bit better off as adults. So I want to talk about really briefly, and that this one will be a little bit quicker, this latest part, is just to talk about what you need to know to safely prescribe bisphosphonates. So the goal of treatment is to interrupt the fracture and refracture cycle, resolve back pain, prevent vertebral fracture, reshape the vertebral bodies, and you want to aim for bone mineral densities that score that's appropriate for your height. Just a quick mention about that. When you do your DEXA is not able to differentiate between a very big bone and a small bone. They'll think the DEXA will think the big bone has a bigger density, which is not true. So that means that the shorter you are, the less or the smaller the DEXA score will be. So you always need to adjust your DEXA score with your height. So that means that you're looking at your DEXA Z-score and you're seeing if it's somewhat similar to what your height Z-score is. And that's an important consideration. If you have a short stature patient, you will expect the DEXA to be lower. So when you treat, you want to take that into consideration to make sure that you're adjusting for that. So I want to go briefly over the side effects, and I will be my last little section in talking about the side effect of bisphosphonates. The most common is those acute phase reactions. So you can have fever, myalgia, typically lasts 24 to 72 hours and then resolves, worse after the first infusion. You can have hypocalcemia. That's why you want to make sure you have a normal vitamin D, and you want to typically give calcium supplement in the days following your bisphosphonates infusion. Respiratory distress is very rare, and that's really seen just in the case of severe OI. So those infants that are born already with a small chest or with a compromise, when you give them bisphosphonate, you might need to intubate them for the duration at which they'll have this effect, which is usually 24 to 72 hours. So that's not a reason to not give the bisphosphonate. It's just a reason to watch closely and probably do that in an intensive care setting if it's a child with severe OI, an infant with severe OI. Renal failure is a contraindication. You want to make sure you're not either not doing it or adjusting your dose. And then there's some effects that are linked to the fact that the bone turnover is less when you give bisphosphonate. And this is really what's called non-union. So whenever a child goes in for surgery and the surgeon actually breaks the bone with an osteotome, you'll have a risk of not healing that bone well afterwards if you're on bisphosphonates. And the trick to reduce this risk is to delay giving the bisphosphonate by 4 months after your surgery. There's no need to stop bisphosphonate after fracture. So fracture is not giving you a risk of non-union. It's really the surgery by the surgeon. Osteonecrosis of the jaw is ultra rare, never reported in pediatrics, so should not really be, I don't really discuss that with my patients. And you can give too much bisphosphonates. That's why we look at the DEXA score, and that can lead to fracture if you're overdosing with bisphosphonates and you have this very dense bone here with very wide, what we call an Erlen-Meyer-Flass deformity. So summary of the side effect of bisphosphonate: acute phase reaction, typically after the first dose, mild hypocalcemia, which is medicated by giving appropriate vitamin D and calcium, delayed osteotomy, which is why we wait 4 months after, and the osteonecrosis of the jaw is not seen in children. So this is my last slide, a high-level summary of everything we discussed. There was a lot of information. So what I really want you to remember is OI can be classified as mild, moderate, or severe. If there's a clinical suspicion of OI based on the history of low trauma lung bone fracture, blue sclera, hyperlaxity, the one most important thing to do is an annual spine X-ray to make sure you're documenting and you're treating for vertebral fracture. Children who have vertebral fracture or more than one major low trauma lung bone fracture should be treated with intravenous bisphosphonates, not oral. Bisphosphonates should never be stopped during growth. They're overall safe, but you always need to ensure you have appropriate calcium and vitamin D and normal renal function before you start them. No need to hold them after fractures, and no need to have a confirmed genetic testing before starting bisphosphonates. That's one of my patients that's now running marathon. She just won the world record for the fastest marathon in a wheelchair. So that's really a beautiful story. So thank you. I'm going to answer questions whenever that's the best time, and I'm handing back the work to Dr. Agostini.
Thank you very much, Dr. Robinson, for the excellent presentation. And we will have a discussion later on. And now I think we will go to the next presentation. Our speaker will be Dr. Speciosa Mbula Nguku from the Machakos Orthopedic Clinic from Kenya. Dr. Speciosa Mbula Nguku, often referred to as Specky, so we can call Dr. Specky, is an anesthesiologist and a pain specialist working in orthopedic clinic in Machakos in Lower Eastern Kenya. She is the co-founder and CEO of the social enterprise called Machakos Orthopedic. Her education experience include a bachelor degree in medicine and surgery, master degree in anesthesiology, and a fellowship in anesthesia from the Society of Anesthesiologists of Eastern, Central, and Southern Africa. Dr. Specky has also trained in Makerere University, Uganda, University of British Columbia, Vancouver, Canada, Yonsei University in Seoul, South Korea. She's passionate about finding solutions for complex problems. At Machakos Orthopedic Clinic, they are currently administering zoledronic acid to 47 patients. So, Dr. Specky, time is yours.
Thank you. So my name is Dr. Specio Sanguku. I'm an anesthesiologist working in Machakos Orthopedics. I am not a surgeon and I'm not a pediatric endocrinologist, but I have passion for osteogenesis imperfecta because I started dealing with it right after residency. And so we want to share our experience with you on our journey in treating patients with osteogenesis imperfecta.
Can you make a slideshow, please?
Oh, sorry. Don't be sure. So I want to share about the overview of our clinic. So generally, osteogenesis imperfecta is quite common in our county. And we've noticed that from the studies that were done in one of the hospitals in Kenya, we found 26.25% of patients were coming from Machakos County. Even within our clinic ourselves, we've also noticed quite a number of children are coming from within the area and the nearby school, where we have where we're also treating quite a number of children. We've noticed that 26 of them are actually coming from one particular school. And so most of the studies that we have been seeing, they're yet to show the effective dose and how treatment, in Africa, that are showing how osteogenesis imperfecta is being treated in Kenya. And so we are hoping that with time, we'll be able to see more of this. So about our clinic, we started our clinic in 2015. And at that time, that's when we noticed we got our first osteogenesis imperfecta patient. And this was a child who was born with a fracture. And at that time, the parents were thinking that this child was most likely had a fracture because they had trauma at birth. But when we saw this child, we discovered that this child has osteogenesis imperfecta. And that started our journey on treating on patients. And so over time, we've noticed an increase in number of patients as the clinic has grown. So one of the thing that helps when I think of this young boy here, he's one of our typical patients. This is a child who is currently now 11 years old. And since he was 1.5 years old, he's had 2 or at least 2 fractures every year and surgery at least once a year since 1.5 years. And so these children like these are the ones that have made us try to think of a solution of what we can do to help reduce the frequency of these fractures. So one of the challenges that we face when you're treating these patients is that they come with several issues. The main issue is that they're fracturing frequently. And so they're having problems with their bone mineral density. Many of them come with severe deformities, and some of their deformities can be very severe. You find they not only have scoliosis, but even their bones are completely bent, and they would be described as though they look like a worm. So instead of it being straight, so you'll find that they're quite curved. And then also they have been having quite a number of frequent fractures. When they have these frequent fractures, this delays their going to school. Their parents are not able to continue with work. And so when these children, if these fractures can be treated, then at least we hope that their quality of life can improve. Then other issues that they also come with, as a family, they also come with issues of finances. When you have a child who is fracturing almost every 4 months, these parents are spending a lot of money on treatment, a lot of time in hospital. And if you remember the picture of the boy that I just showed before, last year, the mother spent almost 3 months in hospital because the child had fractures, and some of it is spending time in hospital fundraising for surgery. And so this has a cost implication on the families. And also the other big problem we find also with osteogenesis imperfecta is that there is lack of awareness about this condition. Many of these children, initially when they come, people think that they have been bewitched. And so they are first not accepting this. They don't realize that this is actually a medical condition. The families may not know what to do, and so they keep jumping from health worker to health worker. And so by the time they come, 3 years later, you find they have very severe deformities. And so knowledge and awareness about these conditions is actually a big gap. And so when we are looking at the treatment, we try to figure out what is the priority that the parents want. So we may be interested in giving the biphosphonates to improve the bone mineral density. But at that time, the parents would be saying, I want the deformity first corrected so that at least my child looks normal. And then afterwards, we can now see how to prevent these fractures. So in our journey of biphosphonates, we initially started in 2015 where we didn't have any biphosphonates available. And most of these children we find had a lot of frequent fractures. Then in around 2017, we had a child who went to South Korea, and when they were there, they had telescopic rods inserted, and when they came with some doses of pamindronate, and that's when we realized that we can actually do something. And so we started giving these two children by pamindronate. We noticed that immediately their fracture rate started reducing. And so that's when we noticed that pamindronate was quite helpful. The things that we noticed immediately is the fracture rate really reduced. Within the first 6 months, some of them would have a fracture, but then with time we noticed that the fractures kept on reducing, and significantly bone pain reduced. And so how we were assessing them for eligibility is after we would see when was their last fracture. If it was within the last 4 months, we were not starting them on zoledronic. And then the deformity. If the parents wanted the deformity sorted out first, so then we would wait. And then the age of the patient would determine when we would begin the treatment. Then coming to 2019, the numbers of the patients grew from around, we started with initially 2, they grew to around 9 patients. And then towards COVID, we had reached 18 patients. But then now, because of the challenges with COVID, we struggled with the availability of pamindronate. We're initially getting it from suppliers, and then we had now to ask other companies to do a special import for us. And then because of the challenges that happened during COVID, the price of pamindronate became unsustainable. It became almost 3 times the cost. And at that time, quite a number of patients dropped out. And when we managed to eventually get it and import it from the UK with a special license from the UK, it became unsustainable. And therefore, we started conversations on what are the things that we can do to improve availability and importation. And that's when the journey towards transition to zoledronic began. And so in 2022, that's when we started with zoledronic acid. We started with a cohort of 23 patients, and we noticed a reduction in fractures, and most importantly, bone pain. The quality of life improved for most of these patients. And some of these children who had actually dropped out of school, we noticed that their parents actually wanted them to go back to school. And so one of the logistic challenges that still persist is continuous availability of zoledronic acid. So the only way our approach is that for us to be able to do this work, we realize that partnership is very important, and the partnerships help with improving drug availability. We also wanted to have these implants that we're using in these children to be available and affordable, and awareness. So we work together with people. So we work together with one of the biggest partners that we've worked with is Health Partners International Canada and GPED, who are the organizers of this webinar. And we want to really thank them because they helped us get the zoledronic acid. So we work together with strategic partnerships. And we've realized that we can only work with this together. So we have partners who are helping us with interventions that are helping with bone mineral density. I've talked about HIPCI, and through our partnership through BC Children's Hospital in Canada, GPED with Professor JP, and Yonsei University, we were able to get some of this medication. We initially were partnered with Yonsei University to get Pamindronate, and then later on these other partners also came along. We're working together with different other partners, our clinic as well as Q International, which is the hospital where we were previously working, which also treats a large number of osteogenesis imperfecta patients. And so they do a lot of surgeries. Also, we work together with them to also not only improve awareness, they also, whenever they see people who could be potentially good candidates, they would send them our way. And if they needed surgery, we would also send them by QR's way so that we'll be able to work together. And so we've realized that we need to work with different other partners like the Pediatric Endocrine Society of Kenya, the School of Disabled, which many of these children come from, and the government facility, so that we can be able to increase awareness and advocacy. And hopefully in the next few weeks, we'll be able to do some screenings in many of these health facilities once we do some awareness and training with the community health workers. So we initially started with Pamindronate as we moved on to zoledronic acid. And with Pamindronate, we were giving it every quarterly. We'd admit the patients for 3 days, and would give the medication slowly over 5 hours to reduce some of the complications like nausea, headaches. But we noticed that it was quite expensive and unsustainable. And as at the end, we were spending almost $73 on a vial. So when we moved on to zoledronic acid, it was more convenient for our patients. We were giving it biannually. They would come the same day. Initially, we were admitting them for an overnight, but then now when we got more confident, we started doing it as a day procedure. They would come into the clinic, we would give them an infusion over 50 minutes, and they would go home. And one vial, we noticed that would cost almost those figures. And just to make the cost a bit cheaper, we realized that if we bring all the patients, we divide them into 2 cohorts coming twice a year, we would actually be able to save more on the drug. And so we'd have these children come in and we'd open each vial and just pick enough drug and use them sequentially on different patients. And that helped to bring costs down. So I would want to tell you a story of, I would want to tell you a story of 2 children. One of them is Amos. Amos, we have seen him since he was around, when he was in high school. He dropped out of high school because he had a fracture and bilateral femur fractures, which were not able to be treated. And he stayed home for 4 years. And during that time, with the 4 years, at 2 years after dropping out, he came to meet with us, and we started him on Pamindronate, and then slowly transitioned on to zoledronic acid. And later on, he told his parents, because he's having less pain and less fractures, he wanted to go back to high school. And he went back to high school 1.5 years ago. And even though he had been out of school for almost 4 years, he was able to pass his exams, and he's going to be, he's been admitted into university this year. And so medications like this are actually quite helpful to people like Amos. When you look at Maxwell, also, he came with very severe deformities. He was unable to start school early. He's 17 years old, but started school at almost 2 years ago. And it was because he was having very many fractures. And so they struggled to find a school that was accepting. And so when they came, their priority was, why don't we start with the deformity correction, and then later on we can transition on to giving the biphosphonates. And so when you think about the road ahead, what are the things that you're thinking about? You're seeing that this drug is actually working. And so we want to see increased engagement with different health workers. And so as we work together, we'll increase advocacy. We cannot do this work alone. We need the pediatric endocrinologists, we need pediatric orthopedic surgeons, and many other players in OI, so that we can be able to increase awareness about this condition, so that we can have early diagnosis and hopefully prevent some of these severe deformities. We are looking to doing more research into osteogenesis imperfecta, and specifically within our region, to understand why we are having such a high prevalence. And then we need to work together with several partners to see how we can mitigate drug shortages. Currently, as we speak, we've been struggling to get zoledronic acid because it's been chronically out of stock by some of these suppliers. And so we thank God for the partnership of partners of people like HPCI and GPED. And the other work that we are working together with GPED and other partners is to see how zoledronic acid can be added to the essential drug list for OI. So last year we hit a big setback because the zoledronic is only being accepted for use in bone cancer pain and but not for OI. And so there needs to be work to see how we can get this in the WHO essential drug list, because at least if it gets there, it easily gets into the pipeline into also the Kenyan one. But for that, we need a lot of collaboration. And maybe one of the things that can be a fruit out of this discussion is hopefully we can do multi-center trials, because WHO needs good data to be able to do this. And so I would like to end with this picture. This happened this week, where we had several children who came for zoledronic acid administration. The young boy on the next to the sink is 7 years old, and he dreams of becoming a priest. The next boy next to him is a 17-year-old, wants to be a journalist, and the other boy wants to be an architect. These are children, many of them would have dropped out of school because of frequent fractures, but we thank God that through partnerships, some of them have had surgery and some of them have had biphosphonates given. And so some of the things that we have learned from the children is that to trust them when they say that a bone is broken, they believe it is true that it is broken. They know how painful it is. And interestingly, these children know where their veins are. So even when you're struggling to look for a vein, they will tell you, the last time, look at this hand, this is where the good veins are. And they are able to be the judge of their level of ambulation. Sometimes you may think that we want to limit them because we think that they will fracture easily, but they have been through this journey. They have noticed the reduction in bone pain. And so they want to explore and do more things. Like the young man in the middle, the last week, his mom was complaining that he was playing football with his friends. And the mom was like, you're going to fracture. So he says, no, mom, I just want to exercise. I need to do exercise. The other boy, the father was complaining that the boy was hanging from trees. So they surprise us. And so we thank God that we have solutions like this. Thank you. I've come to the end of my presentation.
Thank you so much for your wonderful presentation, Dr. Specky. It's really an inspiring experience in Machakos Clinic. And now time for discussion. I saw a lot of question from audience. So I will start with the question. Arnita, can you help to present the question? Okay. So this is the first question from Oman. If a child has acute or chronic renal failure, what is the recommendation for biphosphonate? And what is your recommendation for biphosphonate in spondylo-ocular syndrome and other syndrome which mimic OI? To give or not? And if to give, how long? So I think this question is for Dr. Robinson.
Yes, thank you. So there are ways to adjust your dose of bisphosphonates with renal failure. Typically, what I do with renal failure is I give pamidronate as opposed to cilindronate because it's a little bit more gentler. I reduce my dose and I give it over longer. So you basically want to give a chance for the kidneys to excrete the drug. And if you can do that in conjunction with a nephrologist, that's great. If you can, then I would start with a very low dose, highly diluted. If there is, for example, dialysis patient, then you don't need to adjust because the patient's on dialysis. And so you really just need to adjust if you're trying to save whatever kidneys remaining because you don't want to cause more nephrotoxic harm to the kidneys. For the second question, so there's a number of different types of OI, and depending on the mutation, you can have like pseudoganglioma syndrome. There's different types. At the end of the day, you're treating the bone fragility. So we're treating them the same way, even if they have other features that goes along with their OI. So same regimen of bisphosphonates because they also have bone fragility. And how long you treat until the end of growth. Because that's a genetic condition, the defect will remain your whole life. So you need to treat until all the bone is exposed to bisphosphonates. So when the child's done growing, you can stop.
Okay, so next question. Thank you for your answer. Yeah. And I think this is for Dr. Specky. Support system for OI patient extrapolation in developing countries.
So one of the things that we found that works is that the first thing that we did is we put them into groups so that they don't come alone. Some of these children, their parents were saying this is the first time they're meeting other people who have osteogenesis imperfecta. So when we intentionally made sure that the time when you're giving administration, you're not giving to a single child unless it's just the first time. So we divided them into cohorts. So we have a January, June cohort and an April, October cohort. And so when they come, they would be taken through what the condition is. And even as they're talking with other parents, they'll be able to be reassured. I can just give an example of how support is helpful. In January, we had a cohort where we had a new parent who had a child who was the first time having zoledronic administration. And this was a baby that was a child that is 1 year, 3 months. The mother in the middle of the night noticed that the child is developing a fever. And so she was not able to reach me because we have a general WhatsApp group. And so she posted a question on the WhatsApp group. My child has a fever, what do I do? And so someone else told them what to do. So by the time at least I saw it, someone had responded to her and reassured her. And so that's one of the ways that we found that works. So one of them is bringing them together. We also have a common WhatsApp group where we're able to share stories. And if someone is going through a life event, people are able to talk through it. And then also the other thing we've also noticed is that when they come together, the patients actually have hope. One of the children, the parents made a decision to admit their child in the school for disabled because one of the teachers in that school had a child who has osteogenesis imperfecta. And so while they were in the ward, this mother was able to talk to the teacher, and the teacher told the mother, your son can go to school. Look, my son also is going to school. He even he's on a wheelchair. Why don't you also? So come together. So their support system is not only just us health workers, but among themselves. In December, in March, February this year, one of the children was actually having surgery, and another mother was present to stay with the mother and wait almost 2 hours, waiting for this other child to come out of surgery, even though she had finalized with her clinic almost 7 hours ago. And so the parents are able to support each other in ways that some of us are not able to. And so those are some of the support systems that we have seen that have been able to work. So creating a community where the parents of OI and patients with OI can be able to discuss together and support each other. Thank you.
Okay, thank you. Yeah, thank you so much, Dr. Specky. So we will go to the next question. So I think this is for Dr. Mariev. What are the others differential diagnosis of OI apart from rickets? And what the treatment for children less than 2 years of age?
Yeah, so I mean the differential for OI, so rickets is not really, as I see it, part of the differential for OI per se. So how I see it is that if you have a child with bone fragility, so low trauma fractures, you typically have a skeletal survey. And so in that skeletal survey, you want to exclude other causes of fractures like rickets. So you want to look at your growth plates, see if there are rickets, because if there are rickets, you want to first correct the rickets before being able to say if perhaps the child has OI and also has rickets. So you want to first exclude the rickets and treat it. If you look at the growth plates and there's no rickets and you have a child with low trauma fracture, then the differential diagnosis is primary bone fragility or secondary bone fragility. So primary is genetic, secondary is you have another cause of bone fragility. So typically how I do it is I exclude all my secondary cause. So I would look at basic workup for celiac disease, Crohn's disease, cancer, right? So I would do a CBC. So I would look at chronic illness to exclude chronic illness. And I would look at medications. Is the patient on steroids? That's the main culprit for osteoporosis. So you want to, in your differential, you want to exclude chronic illness that will give you bone fragility or medications. So once you've excluded secondary osteoporosis and you know you have a primary osteoporosis, so you have a problem that you're born with that makes your bone weaker, then the differential is mostly genetic. So you can have a wide range of different genetic mutation that we can call OI or we can call juvenile osteoporosis, doesn't really matter. I call that bone fragility caused by a genetic mutation. And you don't really need to know what it is. It's nice to know if you have genetic testing, but if not, you treat it the same way. You treat it with bisphosphonates and surgery as appropriate. For the second question, what's the treatment for children less than 2 years of age? It's the same thing. So really important, and I know that's sometimes confusing when you look at the literature, but you can start treatment with PAM or ZOL as early as 5 days of age. So if I have a child with severe OI, I start bisphosphonates as early as I can. The main thing to think about is if you have a child with respiratory compromise, usually I would start with a gentler bisphosphonate. So I start with pamidronate to be gentler because that has less side effect, less potential compromise for the lungs. And then I switch to zolindronate. However, if you have a patient that you're not too worried about the lungs and is 5 days old, you can also go ahead with zolindronate and keep zolindronate all their life. So they're both safe in very young kids, as long as you have normal renal function and as long as you have normal vitamin D and that you could give your calcium supplement. And usually the child doesn't need calcium supplement when you're so young because they're either breastfeeding or having formula every 3 hours, which is tons of calcium.
Okay, thank you. Very clear. So I think we go to the next question. Which modalities or maybe scoring system for predicting osteonecrosis of the jaw and atypical femoral fracture as complication of biphosphonate?
Okay, so in children, so people always have those questions, and that's coming from the literature for postmenopausal osteoporosis, where they give a lot of, or even cancer, they give a lot of medications and they have those side effects. In children, there has been no case or no like pathologically proven case of osteonecrosis of the jaw in children that got bisphosphonates, even at very frequent doses. So osteonecrosis of the jaw, I don't worry in kids. The main thing I do is if the dentist will do an osteotomy of the jaw, which is quite rare, then I would delay my treatment, but otherwise I don't. The atypical femur fracture is a concept that we should not use in OI because atypical femur fracture was defined for postmenopausal osteoporosis in the way that the fracture happens, but those fractures happen in OI because there's bone fragility. So when there was this nice study done showing, is there really more atypical femur fracture in OI from bisphosphonate? The answer is no. That is a concept that is really for postmenopausal osteoporosis. So it's really a non-issue for pediatric OI.
Okay, thank you so much. And I think we go to the next question. So this is for Dr. Specky. What type of surgery are done in the patient in Machakos? And to get the government help this patient by putting them underneath, would it be easier to register this patient in a public hospital and you support them in other ways?
Okay. So the type of surgeries that we are mainly doing in Machakos are we are inserting rush rods. So so typically we'll first decide whether or not this is something that needs surgery or not. So typically when you're treating the children, we'd see, is this something that can be treated conservatively or not? Most of the long bone fractures we have to put, like for example, like femur fractures, we put in rush rods, which are just metallic implants that we insert into the rods. We're working towards getting a solution where we can have these implants that grow with the children. So if I were to use my hand, for example, we would put in a rod through here. And as the child grows, you'd find that that rod becomes too short. And so many times these children, they would have a fracture at that level. And so we're looking now for a solution where you'd have a telescopic rod, which will grow, which will expand out as the child grows. So those are the typical surgeries that we do. Then on any other deformity correction. So for some of them who have been on wheelchairs for long and they're having contractures, so we'll also release the contractures so that they can sit better on the wheelchair. Some of them, because of the fractures, their feet could have some bit of deformity, so we'd also do some work on on the feet so that at least they can sit better and also wear shoes. How does the government help these patients under NHIF? NHIF is a national health insurance program, insurance fund, and so this helps to pay for surgeries. So the government doesn't, they say that they pay, it should be free for any child who has the disability certificate, showing that they actually prove that they're actually disabled. But unfortunately, we found that that has not helped. And so the parents have been asked to actually enroll into the National Social Health Insurance Fund. And this is only able to pay for 2 fractures a year per family. And so that has been a huge setback. There are situations where we have a child who has, a family has 2 children, and both of them could have fractures, and that's within that year. And so you're limited to choose what type of fracture, what to ask NHIF to pay for. So one of the things that we've done is that if we find a patient has come from a very humble background, we actually we help the parents register for NHIF, and we've been able to work with some of our partners to see how they can actually pay for these vulnerable children, the social health insurance subscription, and that has helped at least to bring the cost down. And then also, if that is not able and they have exhausted that, we're able to work with some of our partners like Cure, who are also able to assist us in doing some of these patients. And so those are some of the ways we're able to support them. Other times, depending on how severe, of how acute it is, the times when we'd have to find ways to be able to do the surgeries for free. And so those are some of the solutions. And so one of the things that we're working with the county government in Machakos is to see how we can actually screen these patients and see how, as the county can actually have a way of enrolling them into NHIF, and then maybe hopefully they could have surgeries there in the future. But that is something that is on the work in the pipeline with the government.
Okay, thank you so much. And I think we can go to the next question. Are there peculiar finding in calcium and phosphorus level in OI, or is it for the sake of monitoring treatment that doing them are necessary?
Yeah, great question. So it's only for the sake of monitoring treatment. Kids with OI are not at a higher risk than any other kid of having calcium or phosphorus problem. So we do it because if there is, because people are at risk for the general population, then we want to supplement that, especially for vitamin D, if you're deficient in vitamin D before you treat. The one thing that kids with OI have that are a little bit different is the alkaline phosphatase level is a little bit higher sometimes because they have a higher bone turnover. So if you have a very minimally elevated alkaline phosphatase, you don't need to worry. That's part of what we see in OI. It's not clinically significant.
Okay, thank you. Thank you so much. I think we still have several minutes, so we will go to the next question. When will you start IV pamidronate for neonate with in utero diagnosed OI? And if pamidronate is not readily available, do you suggest to use zoledronic in infancy? And if yes, any regimen modification? Thank you.
Yeah, so yes, you can use both IV pamidronate or zoledronate as early as 5 days postnatally. So if your baby is born, usually it takes like, by the time the baby is born, he's stabilized, he might be intubated. What you want to do is you want to draw blood, usually around 3 days of life, if you can, to make sure that creatinine is established, because really early babies, they don't yet have a normal creatinine, and you want to make sure that their calcium is okay. Once you achieve that, so 3 to 5 days of life, you can go ahead and infuse. You could use either pamidronate or zoledronate, whatever is available to you. As I mentioned, if you have respiratory compromise, typically I would favor pamidronate because it's gentler. And yes, you adjust, so the dose is per kilo. So that's if you have a really low birth weight infant, you would give a lesser weight because it's adjusted per kilo. And the interval is slightly different. So, for example, in zoledronate, you give every 3 months as opposed to every 6 months before the age of 2 years. So it's actually the frequency that's changed. And same thing for pamidronate, you give it more frequently. So every 2 months instead of every 4 months in the early stage before 2 years of age.
Okay, thank you. So next question. Is there possibility to get less fracture without having zoledronate or pamidronate? And is there possibility to still have deformity and severe pain even if you take PEM or Zole?
Yeah, those are great questions. So typically in genetic forms of bone fragility, so if we talk about OI, you will have fractures if you don't treat until you're done growing. So by definition, the course of fracture is high. It's really high in puberty because the bone is growing fast. It's kind of unstable. And in adulthood, it's going to go down regardless of treatment because the bone is kind of done. It's not as, the shape is not changing. So it's more stable. So you'll have less fracture. So that's good, just a natural history. But there's no other ways right now to decrease fracture rates except then bisphosphonates or surgery. So that's another thing to mention is surgery is to correct the deformity of the bone. If you have a really severely deformed bone, you can give all the bisphosphonate you want. This bone will fracture because of the geometric nature of the bone. You'll have a peak that has a lot of stress and you'll fracture at that junction. So pamidronate or zoledronate have so much effect on the deformed bone. You need to correct the deformity. And then the bisphosphonates can also work to increase the density, but it's not going to help the shape. And I just going to allow me to say, if the patient is really keen to have the deformity corrected because of cosmetic issue, one important consideration is bisphosphonate can be given at any time before surgery. It actually stays in the blood only for 24 hours. So you can give bisphosphonate as early as 24 hours before surgery, and it is going to be okay. So there's no reason to delay bisphosphonates before surgery is done. So I typically start, if you have an OR book, doesn't matter, I start right away and I just make sure there's 24 hours in between my dose of bisphosphonates and the surgery. The second question, so is there a possibility to have deformity and severe pain even if you take bisphosphonates? Yes. So bisphosphonates are not that good at changing the shape of the bone or the deformity. They're actually useless. They're not working on that level. So the deformity is not helped with bisphosphonates. The pain is helped though. I rarely see kids in severe pain on treatment. I see kids in severe pain when we stop the treatment or as adulthood, but bisphosphonates are pretty good to manage the pain.
Okay, so thank you. And the next question, we still have a lot of questions here. And what is the indication for stopping biphosphonate therapy in adolescent?
So if you have an adolescent with any type of OI, if they're done growing, and so that means that no more than 2 centimeters per year, the growth plates are fused, you can stop therapy. Even, and that's sometimes surprising, but even if your DEXA or your bone density is low, the effect is quite minimal in adults. So you can stop when they're done growing, kind of unless they're really unwell or having lots of fracture, maybe I'll keep going, but usually by the time they're done growing, we stop. There's one time where we don't do that, and that's pain. So if you try to stop, that's usually the course. If, okay, your child is done growing, you try to stop, and then 6 months later, they come back in severe pain. That's when I'm going to restart, but I'll restart at a different interval. I'll ask them, how long does the effect last on your pain? And they might tell me 8 months, 9 months. So then I'll say, okay, I'll give you bisphosphonates every 9 months to manage the pain. So that could be an indication to not stop, but otherwise, as soon as they're done growing, you can stop.
Okay, thank you. And the next, how often we use bone mineral density to evaluate treatment using biphosphonate? And how about the effectiveness of using oral alendronate compared to zoledronic acid?
So bone mineral density is typically done every 6 months on patient with bisphosphonates. If that's not doable, every year is okay. I wouldn't do it less often than every year because you want to adjust your dose based on that level to avoid over-treatment. That's why we're monitoring so closely. We want to avoid over-treatment. So we want to reduce the dose if we see that the DEXA score is going into the normal range. Oral bisphosphonates like alendronate should not be used in kids with OI that are growing because it doesn't protect their spine. So kids on oral bisphosphonate, the studies have shown that they continue to have vertebral fracture. It doesn't help vertebral fracture, so we don't use it in pediatrics.
Okay, so we still have, I think, 1 or 2 minutes. Maybe last question, Arneta. So this is the last question, I think. And maybe for other questions that we cannot answer here, we can have, you can email GPED and then we can give to the speaker. So the last question is about do you recommend pamidronate or zoledronic acid for patients with mono or polycystic fibrous dysplasia? Are you recommending using bisphosphonate in this patient even if they do not have pain or fracture, but when under orthopedic surgery? And after how many fracture and what type of fracture we can screen a child for OI?
Okay, so I'll do a rapid fire because we only have 1 minute. First answer is you only treat fibrous dysplasia with bisphosphonate if they have pain. There's no evidence that bisphosphonate will change the fibrous dysplasia itself, but it can help the pain. The second question, there are some instances where I would give bisphosphonates even if there's no pain or fracture, and that's for spinal fusion. Surgeons subjectively tell us that they have a better time doing a spinal fusion when the bone has been exposed to bisphosphonate. This is not evidence-based, this is subjective. So you wouldn't be wrong to not do that, but I do it and surgeons find it pretty helpful. I don't do that for long bone surgery, so rod insertion. Subjectively, the surgeon tell us it's easier to insert the rod if there is been bisphosphonates, but it's not a reason to treat. But typically, if the kid is severe enough to have deformity, they're fracturing. So it's quite rare to not have a situation where they're not fracturing. And how many fractures and what type of fracture can we can screen a child for OI? So you just need one low trauma fracture that I would screen. So if you're fracturing at a low trauma, so no more than a walking speed, no more than a sitting height, or then that's a risk for fracture. So I would screen if there's one low trauma fracture of a long bone or a vertebral body. I don't screen for hands, knees, feet or nose, it's really long bone or vertebral fracture that we screen.
Okay, so thank you so much. I think we still have a question, but the time is up now. So thank you so much for your very fruitful discussion. And I think this presentation helped us to know more about the biphosphonate treatment and also how to manage OI in developing country. Now, I think I will go back to JP. Yeah.
Thank you very much, Agostini. And so in particular, thank you very much, Marie-Ève and Specky for this very, very nice presentation. And this has generated so many interesting questions. I think that for me, these lectures also highlighted the barriers and the opportunities in providing optimal treatment for OI. And I just want to highlight a few things that I remember from the two lectures. First, Dr. Specky talked about the inclusion of parents groups such as WhatsApp groups. And if you go further, advocacy by parents group does play a major role in advocacy, and governments are listening. And if you have parents group that have some opportunities to make some noise, then this could be radio, this could be TV, this could be newspaper, but as a group, this has way more weight than simply independent parents complaining about the lack of treatment. So I would really encourage and congratulate Specky for this WhatsApp group and also for the role of the parents. From Dr. Marie-Ève Robinson, we have heard that IV biphosphonate are better than oral. And from Dr. Mbula, that pamidronate, which is slightly less potent option compared to zoledronic acid, but still viable, is more expensive than Zols, but also requires more admission time in the hospital. And this is also our experience. When we shifted from pamidronate to zoledronic acid, one of the selling points was that actually it required less admission of our patients and therefore less nursing time, less hospital times, less bed time. Another thing I remember is that this webinar today was an opportunity to bring together health professionals within Kenya, and we have trying to create a multidisciplinary coalition of health professionals so that they can together make the request for a sustainable access to biphosphonate in a much stronger manner. And I hope that you will build on our webinar today to really work together, because I think that you have a lot of expertise everywhere in Kenya, and we should be able to get this product available for our patients and for your patients in a sustainable manner. How do we get there? Well, the last thing I wanted to say is that Specky did talk about the WHO essential list of medicine. and as a step towards registration of the medicine in the country. It's only a step, but I was very interested to hear that Kenya does have zoledronic acid, but mainly according to the indication presented by the WHO EML, which is cancer pain. And indeed, WHO does not list OI as an indication for zoledronic acid in its list. We tried, GPED tried 2 years ago, and we were actually not approved. And I think that, well, we need to start again. And I think that we now have maybe more interesting data to provide, and hopefully make it come to the essential list of medicine in the next edition. Normally they go to this about every 2 years, but this is something GPED would be happy to discuss if anybody was interested. So I think it was an excellent webinar, and I really thank you so much for taking the time to listen to us, to ask the questions, and specifically to the speakers and to our moderator, Dr. Utari, to lead these questions and this webinar. And I invite you to the next webinar, which is indeed on thyroid. I think we are going to talk about Graves' disease and newborn screening on May 31st, and this will be organized by Dr. Utari. Thank you very much, and it was a pleasure to have you all around the screen.
Thank you very much, Professor JP. Once again, on behalf of the organizing committee, we would like to extend our warmest round of gratitude and appreciation to all our speakers and moderators, Professor JP, Dr. Phoebe, Dr. Mary Eve Robinson, Dr. Agustini Utari, as well as Dr. Specky, for incredible lessons and insights that we have learned today. Of course, no event is complete without a photo session. We now invite all our honorable guests, speakers, and moderators to once again turn on your videos to take a group photo. To all the participants, you're also welcome to join the photo as well. We also have Professor Aman Pulungan here, who is actually our keynote speaker for the next webinar. And we invite you, Professor, to be in the group photo as well. So if you are keen to learn more from world experts, including Professor Aman, please register for the next GPED webinar. Okay, I will now be taking the photo. 3, 2, 1. Okay, we will have more photos as well because there are a lot of participants. 3, 2, 1. 3, 2, 1. All right, that concludes the photo session of this webinar. So all the participants kindly fill in the feedback form as detailed on the slides and has been sent via the Zoom and YouTube chat. The certificate of attendance will be shared via email upon completion of the feedback form. Global Pediatric Endocrinology and Diabetes conducts routine webinars as well as other very exciting activities and opportunities for you. The next GPED webinar is coming up in just 3 weeks. Register for the GPED World Thyroid Day webinar via the link on the slide and the links that have been sent via the Zoom and YouTube chat. We will also be having the GPED annual meeting coming up this November. Register to become a GPED member via the website as seen on this slide. And to keep yourself up to date, we urge you to follow GPED on our social media platforms as detailed on this slide. Once again, warmest round of gratitude to all parties who have made this webinar a great success. Thank you, and we hope to see you at our next webinar. you.